Hi everyone, welcome to the 4D show. I am Dr. Prashant Arun, consultant physician and diabetologist at MB Hospital for Diabetes, Chennai. And today's topic is challenges in diabetes care in India. So, when we say challenges in diabetes care, most of them don't know that they have diabetes. They either go to the doctor for getting tested for some other reason, and then they come to know that they have diabetes because people are not aware. Most of them are not aware, and other few people they don't want to know because even if they have symptoms, they are scared to get themselves tested because then they'll have to be starting taking tablets or they'll have to be on insulin, and they are scared what their relatives are going to say. But they just don't know that the complication is going to be worse, and by delaying the diagnosis of diabetes they're going to lose their beta cell function, and later on they'll be having to take insulin lifelong. So we have with us today Dr. J Kishore. He's a consultant internal medicine and diabetologist in Ashok Diagnostic Center, Bhubaneswar, India. He's going to be talking to us about the challenges in diabetes care in India, whether it is the sheer numbers, lack of awareness, or the inadequate control. So on to you.
Uh, Thank you, Dr. Arun, for your introduction. And very rightfully said by Dr. Arun that we pose great challenges in the diabetic care in our country. And this comes in terms of the number of people who are affected with diabetes, lack of awareness, and inadequately controlled diabetes, which could lead to a great deal of complications and thereby have a great economic burden on part of the state. If you look at the numbers, there have been a great increase in the numbers over the recent years. And if most of you may not know that in India, 1 in every 11 adults uh, are living with diabetes, and over 1 in 2 adults are living with diabetes who are undiagnosed or in a pre-diabetic state. And the number of people with diabetes in India is the second highest in the world. So we have a great burden in terms of treating diabetes patients, and about 40 million adults in India have impaired glucose tolerance, which is the pre-diabetic state, and it places them at a high risk of developing type 2 diabetes. And the rise in number of patients with diabetes are because of a very complex interplay of various factors like the socio-economic, demographic, environment, and genetic factors. We tend to have a great amount of genetic predisposition. And if you look at the other factors which could also contribute, could be the lack of physical activity, which has been very drastic now with this concept of work from home, and increase availability of processed foods like high calorie dense foods like burgers and pizzas and other things. And we have a increasing burden of the aging population because of increased life expectancy, and the overeating and lack of physical activity increases the obesity and overweight, and they could be the precursors of development of type 2 diabetes. And regarding the awareness or the perception of diabetes in our country is very bad for the sheer fact that a lot of the urban and the rural populations are not very conscious about the diabetes. Next slide. So, looking at the lack of awareness, there was a study called, which was done called the ICI study, which refers to an improved control India study. And from the doctor's point of view, it is seen that the tendency to prescribe tests, that the various tests which are prescribed here, as you can see, HbA1c is prescribed in hardly 19% of the patients, and lipids are a little more, 23%, and BP and weight and all are routinely monitored during the examination of the patients. And if you see in the fasting and postprandial, they are the only two tests which are regularly advised by your doctors. And looking at the patient's point of view, it's very startling to know that about 67% of the patients were not aware that they had diabetes. And according to this study, 19% of the patients were advised to take only HbA1c levels routinely by the doctor, as shown in the bar graph, which I've already shown you. And moreover, only one-third of the patients included in the study were aware of the importance of HbA1c in the management of diabetes. So it is basically that most of the doctors were advised fasting and postprandial to the tune of 90 to 96%. And HbA1c was considered an important parameter, but the testing frequencies were not as routinely done. And sometimes they were advised to test once in 6 months or a year, and very rarely you find patients, the doctors prescribing tests of HbA1c once in 3 years. Next slide. With the huge numbers and lack of proper awareness from the patients and from certain physicians, this is the main reason why the inadequate control also will happen. And it is seen in our country, achieving and maintaining glycemic control in patient diabetes is very, very important for the overall health and survival, because if you don't do it, you tend to have a lot of complications which will increase mortalities and morbidities. However, patients with diabetes often struggle to achieve this control, and the recommended target of HbA1c could be because of the following reasons: lack of general awareness, as I told you, about diabetes and its complications; diagnosis and access to treatment for diabetes, especially in remote areas, are very, very bad, and some of the tests done there in such places will not be very authenticated. And the economic disparity between the urban and rural settings could be one of the factors why people don't achieve, because the majority of people in our country live in rural qualifications, rural surroundings, and scarcity of qualified health care professionals to manage diabetes are to be glaring in our eyes, and monetary constraints and so much other constraints which will add to the process of inadequate control of diabetes. So how do we really manage diabetes in our country? There are certain factors we have to look. We have to see that the diet and regular exercise is followed by the patient, and they need to keep an eye on the blood sugar levels and be very aware and reach the doctors in times where the sugars are not under control. They have to be very regular with medications, because most often we find in our day-to-day practice with the patient, if you have taken 2 tablets, you will be just taking 1 tablet because of some misconceived attitude or because of financial constraint. And controlling of cholesterol is also very vital because that will help to prevent a lot of complications. And most of the patients do not take this medication thinking that it was unnecessary. And we need to see that the kidneys are also, since they are the target organs which are affected by diabetes, the kidneys are kept in the optimal state of health. And we need to lose weight, especially with the people who are obese and overweight. And we need to also see that we practice good oral hygiene in terms of cleanliness. And medications which have been prescribed have to be taken very, very regularly by the patients in order to help us achieve the target controls. Coming to our diet, the Indian dietary pattern is very, very important, because we eat a lot of carbohydrates and or foods which are high in glycemic index, and that's the reason why most of our patients tend to have a higher postprandial blood glucose level than what we have in the Western population. So we need to include low glycemic index foods like whole wheat, brown rice, oats, etc. in every meal. We need to avoid refined cereal products like white bread, noodles, white rice, and other things which come into the category. Exercise is very, very important, which is often most overlooked in the terms of self-care by the patient, and they should be monitored and counseled to do exercise regularly. And we also need to tell them that during the exercise protocol that the medications have to be looked at from time to time. Blood sugar levels have to be maintained, and it is important to get the HbA1c level test done either twice a year or once in every 3 months in order to achieve the desired HbA1c level. And medications, according to the prescribed medications, the patient should adhere to these medications, and missing doses should not be encouraged, and the patient should be following a very healthy lifestyle habits. Next. So, what are the basic treatment strategies for diabetic patients? It is very, very important. Many a times you have need to maintain a positive or a good glycemic legacy. For this, it is very important that the patient should have achieved the target control of blood sugar and HbA1c within the first year or two of diagnosis of diabetes. Hence, we need to also initiate combination therapy wherever required by the patients, especially those with a higher blood sugar levels and higher HbA1c levels, and combinations with the various molecules, be it metformin, or you have SGLT2 inhibitors, you have D4 inhibitors. It could be very good ideal combinations, and also you can add sulfonylureas. And what I mentioned is about the novel medication therapies that are basically available now in the market, and they are used along with diet and exercise to control high blood sugars. A few of these examples have been enumerated here. We have D4 inhibitors, which has very unique mode of action, like sitagliptin, saxagliptin, linagliptin, and alogliptin. We have the SGLT2 inhibitors like canagliflozin, dapagliflozin, empagliflozin, and we have a GLP receptor agonist, both the injectable and even the recently introduced oral semaglutide.
So that was actually, we've come to the end of the presentation. That was a wonderful presentation by Dr. Kishore. So we would just want to find out what are the personal challenges that you come across in your clinical practice with patients with diabetes.
Some of the factors which I have enumerated also do hold good in my clinical setup, but adherence to your treatment and frequency of intervals you see the patients have to be maintained, because you can't see a patient now and the patient comes back to you after 6 months, because by the time you achieve a good control, it could take about 3 to 4 years. So I normally practice that the patient, till he is controlled, I ask him to come every month, and then after that I tell him that once every 3 months he can come and follow up. But I tell him that following regular backup with the doctor is very, very essential. So we do have sometimes patients we prescribe medications not adhere to, and we cannot be really angry on them, and then we need to counsel them that how important it is in order to avoid the sufferings which can happen in the later years to come.
Yes. And next because always we say prevention is better than cure. So when we spoke about pre-diabetes, because most of the patient end up coming to us doing just a fasting postprandial HbA1c to detect diabetes. And most of them actually come and stay off in that 6.4 HbA1c, and it becomes technically difficult to brand him whether he's got diabetes or not. So where would we say, because GTT is much more better when diagnosing diabetes. So what is your opinion on this?
It's very right that patients do come where it is borderline 6.4, and for them, I would prefer that they should follow a very healthy lifestyle habits, and some of them have a genetic predisposition in terms of family history of a strong diabetes mellitus. And in those cases, whenever such patients come for any other disorder and they are doing a blood test, I won't hesitate to include a random blood sugar rather and HbA1c in order to detect, because sometimes doing just a fasting is not good enough. So I would prefer to do a random and HbA1c so that I try to catch them at the early phase, most of looking at the family background. And otherwise, we have to be very vigile and follow up such patients who are on the borderline, actually.
Okay. What is your opinion about the SGLT2 inhibitors, the DPP4 inhibitors, and the metformin? That is a triple drug combination. That is, what is the view on the three combinations that it will help reducing the burden on diabetes?
They're very unique in the sense sulfonylureas have stood the test of time, but still sulfonylureas don't have the extra glycemic benefits what you have with these molecules. We have been using these molecules in a separate, like we had metformin D4 inhibitors right from beginning, or I had a metformin SGLT2. So getting these three molecules will definitely help the patient in terms of compliance. And from my personal view, I've seen that we tend to start the SGLT2 inhibitors, D4 inhibitors, and metformin in the earlier stage, and add sulfonylureas as and when required in smaller doses in order to make the final titration before the patient achieves his HbA1c. So I think combination therapy is very good. We have used with the recent introduction of various companies, and they have been quite compliant with it. So that's good combinations.
Where would you place the acarbose, voglibose? Because these days many people are talking about SGLT2 inhibitors, DPP4 inhibitors, but nobody is actually talking much about acarbose, voglibose. So in your set of practice, where would you use acarbose, voglibose for patients?
See, we will not use them as the first frontline therapy. I use these AGIs basically when I need smaller adjustments. So that is the thing, number one. Number two is that when I feel that the postprandial is a little higher, then we have combinations of metformin, sulfonylureas, and alpha glucosidase inhibitors. So that also we use. But coming to this triple therapy and the place in AGI, I think the finer titrations can be done with the AGIs. You can place the AGI in the lunch, and they're in that way very good. And you can use these molecules also in patients with CKD. So they will be used, but not as widely. But they will be in the process of fine tuning your therapy. I think AGIs are very good.
Yes. So how do we titrate the basal insulin, so premixed insulin, or where would you choose a basal insulin, and where would you choose, on which set of patients would you choose a premixed insulin in your clinical practice?
Basal insulin, number one, if you find that the fasting is relatively higher than the postprandial, definitely basal, number one. Number two is that if I need a little active intervention in terms of therapy, when I have already exhausted my options, then adding a basal therapy would be most ideal. And a premixed, definitely when we have used the second generation basal insulin with the premixed. So those also we have also used in certain situations where you find that the postprandial is high and the fasting is a little on the high side, but we have even placed it either before breakfast or before dinner as a need be, or before lunch also, continuing the oral. And using totally premixed insulins with or without metformin, D4 inhibitors, SGLT2, they can be used in order to reduce the doses of insulin requirement. I think this is the way normally I do that.
Yes, because most of the Indian population, the carbohydrate is actually more in every meal. An Indian person has more of carbohydrates. So definitely, I think we'll need some. So when you start,
making a comment on that, I think even yesterday one of my friends asked, we tend to use more of 50-50 also in comparison to what the Western population use. So 50-50 is a good option combinations.
Yes, actually, my personal best in premixed insulin is 50-50 because it actually takes care of the postprandial blood sugars also well.
Absolutely, absolutely. So he was asking me, how do you do? I said, no, if you feel that the postprandial component is very high, instead of using 30-70, use a little more of short acting in the form of 50-50. And I use a lot of 50-50.
Because I feel 30-70 works mainly when the fasting is mostly on the higher side, but when
Yes,
the
yes, yes,
postprandial is there, I think it's always the
absolutely,
50-50 that actually works much more better.
absolutely.
And for the Indian population, even if you enter a house, they greet you with carbohydrates. So,
Absolutely.
so when you start a newly detected patient on diabetes, when you start, would you prefer starting them on metformin and lifestyle modification, giving them some time to see if they lose weight and they try bringing down their blood sugar, or would you choose adding two drugs and
See, if the patient is obese and I know most of the people are not adherent to the advice you give in terms of lifestyle. So adding molecules of benefit in terms of his weight reduction, like a metformin and SGLT2, would be an initial preferable combination. Uh, Besides, whatever the recommendations say that you have a established ASCVD or that's putting that aside. I think patients who tend to have more of obesity or overweight and poorly controlled, I think combination of metformin as SGLT2 inhibitor in the beginning, along with lifestyle, could be a good option.
good option?
And that is there. And some people are there is very marginally increased, so just metformin and lifestyle with the dietary advice. I think that also does help. But more often we tend to give a little of either a D4 or a GLP.
Yes. How do we address the vitamin B12 deficiencies with patient on metformin? Because most of the patients on metformin develop vitamin B12 deficiencies on the longer run.
I don't think we have much of that problem because they say in the long-term use of metformin, more than 2 years, you tend to develop vitamin B12 deficiency. I have never seen as such. That's number one. Because estimating vitamin B12 for a general population, it may be a little more he has to spend. Rather, I would prefer that he estimates some other thing in place of that money he spends. HbA1c could be a better option to test rather than B12. That's number one. Number two is that you find most of the patients in their prescription, invariably you have a B12 prescription. We have a calcium and a B12 combination we use. So I don't think we face that much of a problem. Unless otherwise the patient is an alcoholic. Okay.
Alcoholic. Yes. Now that we have spoken about DPP-4 inhibitors, SGLT2, metformin, and sulfonylureas, what is your role and where would you place the glitazones? Because initially we had the pioglitazone, now we have the lobeglitazone.
I've been using quite a bit of pioglitazone and it does work very well. And if you look at the degree of HbA1c reduction, I think it is pretty good. So I have used because certain of the compounds are there in combinations. You do get like glycoside, metformin, and pioglitazone combinations. I've been using. Say, suppose a patient who's on glycoside and metformin combination not controlled, you can give a single pill combination of these three with pioglitazone and see before you make any further changes to his therapy or this adding on insulin. So we have, I have used quite a bit of this combination and using pioglitazone up to 15 and 30 milligram, that's okay. I think we should be using that quite often. And using them in combination with SGLT2 inhibitor will mitigate the chances of pedal edema and have an additive effect.
What are the precautionary measures or which set of patients would you be very careful while adding the pioglitazone?
Number one, congestive heart failure. Number two is the elderly, because most of them are osteoporotic. And any patient who has a history of osteoporosis or a pre-existing pedal edema, I don't want to use pioglitazone and cause because most of the elderly tend to have chronic venous insufficiency. So in those cases, adding a pioglitazone will again, they'll be too worried. Even though it's not going to cause much of a problem in terms of physical fitness, but having a swelling in the patient is really worried. So I don't add in these three conditions.
Sure. Now that we've spoken, the SGLT2 inhibitors, mostly because most of them are even scared to start SGLT2 inhibitors because they think that the patient might develop urinary tract infections. But when we weigh the risk to benefit ratio, definitely it's been more beneficial. And definitely UTI, a person with diabetes, because of the urine glucose, is already high risk of developing UTI. So we cannot be blaming only the drug for developing UTI. What is your opinion on this?
If a patient has already, before you start this, he has a pre-existing UTI, then maybe you can wait till you treat the UTI and then start. Patients who have had genital infections, I normally treat them because of high sugar, as you have said already, they tend to have mycotic infections. So I treat them and then see if it doesn't cure. I think in that case I would put the lens over SGLT2 and then try to change it. Otherwise, with one episode of a mycotic infection or a urinary tract infection, I won't be tempted to change because the amount of benefits are derived from this molecule.
Yes. So it was a wonderful session with Dr. J. Kishore. Looking forward to having more sessions with you. Thank you.